Hello, and thanks to you for listening to this presentation on our project, Improving Wrist Injury Pathways. This is aimed to just summarise where we are now and give a background of the evidence. So we know wrist injuries are really common, first of all, and there's about 50 to 100,000 patients per year who have an injury, tenderness around the scaphoid, pain around the scaphoid, and normal x-rays. The evidence is pretty clear that MRI scans are the best early investigation for this group of patients, and therefore the NICE guidance advises early MRI scans to be used for this group of patients. So there's good evidence that early MRI is cost effective, and the SMART trial run out of Guy's and Thomas's in London demonstrated that it saved around £300 per patient using MRI as opposed to repeat clinical assessment and then further imaging, depending on the clinical findings at the repeat clinical assessment. So not only did the SMART trial show that early MRI was cost effective, but it also showed that patients were more likely to be very satisfied with the information they received, and it also showed they were more likely to strongly agree that their care pathway improved their care. There's only one other randomised clinical study looking at this research question, and this was done by Patel et al. In 2012, and they showed MRI was marginally cost effective and there were trends to better patient satisfaction and less pain in the early MRI group, although these differences weren't statistically significant. NICE, which is the body in the UK that generates clinical guidelines based on the best available evidence, did a whole body of work modelling the cost effectiveness of early MRI and concluded that immediate MRI is likely to be the most cost effective imaging strategy for patients with a suspected scaphoid fracture. Off the back of this, we then did a national survey around 3 years ago of 87 centres in the NHS, and this showed that only 14% were able to offer early MRI from the first clinical presentation of a patient to that hospital's service, demonstrating that it's clearly not easy to actually deliver the early MRI scan in practice. So that's really the backbone to the project. From the patient's perspective, I think it's a no-brainer. You want to know if you've got a significant scaphoid injury or not. If you do, you want to then be treated, and if you don't, then you can generally get the wrist moving, get on with things. For a clinician, it's much better to have the investigation and to be able to deliver the early MRI because it gives you the certainty. It makes life a lot easier for you in terms of answering patients' questions and actually to deliver a nice, appropriate, prompt management plan. And then from the hospital's perspective, it makes sense because you will save money by reducing the amount of patients coming through your clinic, as this is generally very expensive when you look at the health economics, and also potentially you can save money in terms of litigation. Big thanks to you for listening to this first part, which has been a summary of where we are now and the evidence. Coming up will be a summary of what we've done so far in terms of finding out more information about wrist injury pathways and then presenting what we plan to then do about it in the future going forward. Thanks very much.